Okay, tutorial scaling video for an SRP, anesthetized patient, super stubborn mesial and distal calculus that is still showing up radiographically. Here are a couple examples of our typical scale and route planning patients. So I've been a hygienist for 26 years, and for the past 9 years, I have been working full-time in the homeless shelters. This is a technique I came up with and it seems to work for me, so let me show you and see what you think. So traditionally when we go in and do our Gracie 13-14 on the distals of teeth, we're going to slip into that distal buccal sulcus. We are going to try to get subgingival, and right away this is where I think a problem happens. That angle that's running across diagonally on number 29 is really prohibiting me from going much further interproximally, and as I do, I'm losing the depth that I was at. Also, this motion of this backhand is very limiting on the amount of power and precision you can still keep on that tooth in a back stroke. So what I like to do is I move to the 6 or 7 o'clock position. So my feet are facing that way, and I like to stand for this quadrant. My right hip is basically at the patient's upper arm, depending on how tall they are. So first, before we get into this, let me explain. All of this white and dark stuff that you see in the mouth and on my scaler is fake calculus. We use this for tutoring. And I also want to let you know that I have the scaler in one hand and the camera in another. So if things get blurry, I'm sorry. I'm trying my best to do this one-handed. So what's important to know is look at the cutting edge of this Gracie 13-14. Its length is that same distance between lingual and buccal on the distal of this number 29. So if this instrument is inserted correctly subgingivally and you are doing that upward stroke, pulling just a little bit towards you anteriorly, you are going to clear that entire distal surface from lingual to buccal with calculus. I still like to go just a little bit after I do it the traditional way and just clear this distal buccal line angle, but traditionally there isn't even anything there because I did such a thorough job coming from the lingual. So something else to note is when you are doing this, you want to make sure that you're just not going interproximal. It's not a go-between. It's not an interdental brush. You really need to make sure that you are in that distal lingual sulcus. Also make sure that your cutting edge is correctly positioned towards the distal of number 29. You do not want to accidentally clip that interdental papilla. So I am going to see if I can show you this. I lead with the tip of the 13-14, and depending on the patient's pocket depth and how loose or tight the tissue is, you're just going to be guided subgingivally, and all of a sudden you will just fall into that pocket. So all of my instruments, I think I mentioned, are marked at 9 millimeters. So I know how deep we are. So I'm at 9 millimeters, and I am going to scale up, keeping that cutting edge towards the distal of number 29. My wrist is in a totally neutral, straight position. It is not bending backwards. I'm going to see if I can show you here. If I get this interproximally just right, you may be able, do you see my scaler coming through on the distal buccal there? So you're able to clear that entire distal, like I said. So I will continue to move back to number 30. Again, we're going to lead with the tip of the 13-14, a little bit of a wiggle depending on the patient's tissue, and then you'll be able to scale up and down, starting at that lingual line angle, moving more interproximally and getting to the buccal. I will also be able to do the very distal of number 32, just finding that sulcus I'm in and doing that same up and down stroke from the distal lingual line angle all the way over to the distal buccal, and then just going back and just double checking by doing a little bit of scaling on that distal buccal line angle. So let's go ahead and let me move my, let me mention this right now. A bite block is 100% necessary for doing a quality scale and root plane. I have never not used a bite block. So if you're not using a bite block and you are trying to apply that intense pressure to get off that tenacious calculus, you are basically just playing tug of war with the patient's jaw. It's moving around and flopping around. You need to have a very stable stage to fulcrum that rigid fulcrum finger on. One thing I'm also seeing with a lot of newer grads is that their fulcrum finger is not as rigid as it needs to. It's kind of like a noodle. When your fulcrum finger is not firm enough, like a nice kickstand, you are not going to be able to apply that necessary pressure to get off that calculus. Let's go ahead and do the mesial buccals. All right, so here we are. I will use an 11-12 or a 15-16. Traditionally, what we'll do is go ahead and enter on the distal buccal line angle. We'll do my direct buccal scaling, the same as the traditional way. Okay, it's a little just hard on rubber gums. This is where I think things get awkward again. As you're coming around that mesial buccal line angle, again, you're doing a backwards stroke on the mesial of number 30. You're losing a huge percentage of the power and the precision. Anything that you do in life that's the backhand is not as strong and precise as doing something forehand. So what I do is I like to come to the 11 or 12 o'clock position. So I am standing kind of behind the patient, and I am going to, with my 11, 12 or 15, 16, I'm fulcruming on the tooth that I'm working on, or just a one distal, and I'm going to just slip underneath the gum. It honestly goes in really easy. Again, I am at, about 7 millimeters, and I am going to scale up, making sure that that cutting edge is in full contact with the mesial surface. And let's look again at that cutting edge on the 11-12. Look at that, its distance is almost exactly from the lingual to the buccal. So we're going to go ahead and insert again. I'm going to do that mesial buccal, slowly walking more interproximally. And sometimes on a real person, not these rubber gums, you can see, there we go. You can see that I'm subgingival, but I'm clearing that mesial lingual. So I still will, for thoroughness, come on in and I will scale that mesial lingual, but typically there's nothing there because I got a majority of it from that buccal side. So we'll go over to number 30, mesial buccal, same thing. We're going to slip subgingivally and scale up and back towards myself, walking it from the mesial lingual, the direct middle, all the way over to that mesial buccal line angle. I will do this same technique on prophies also with a universal sickle scaler. So here I have just a 204. I guess you could use like a Barnhart, even a 204S. Well, 204S might not be as good to go as far interproximally, but let's just say this pocket is 2 to 3 millimeters. I'm still in this 11 to 12 o'clock position. Let's go ahead and start to scale, walking slowly interproximally, getting all of that out. So then we'll actually clear it also from the lingual side. Typically there's nothing there. So I will still do my traditional scale with this, where I'm walking it, come around the mesial buccal, but I will always follow up on this lower right quadrant by inserting from the 11 o'clock to 12 o'clock position. Okay, the next thing, let's do mandibular anteriors. All right, mandibular anterior, scale and root plan, patient is anesthetized. This is not the scaler. There is no way an anterior sickle is going to be able to do a scale in root plane. You're going to get maybe 3 millimeters, maybe 4 underneath the gums, but you're still not going to be able to get all the calculus that's down causing this tissue to look this way. And if you had a 5 or a 6 millimeter pocket on the direct facial, you're never going to be able to reach it. So my all-time favorite instrument is the SAS 1-2. They also make an SMS 1-2, which is the same instrument, but the cutting edge is even more petite. Okay, so with this scaler, okay, I'm going to insert my favorite scaler, Micro Mini 1-2 subgingivally, and just kind of let you hear these tiny little micro overlapping strokes, getting off all of that grainy calculus subgingivally. Let's go from the facial side, subgingival, firm overlapping strokes. So you can see that there is just no way that anterior sickle is going to get into the sulcus like this and remove this grainy calculus without causing any tissue trauma. Even an 11-12 is way too bulky to fit subgingivally and do these micro movements. I also love this for maxillary anterior. Be able to take it subgingivally. Getting off all that calculus. So anteriors, that's a whole nother video. One thing that I forgot to mention in the beginning is, yes, I do use the ultrasonic a lot before I hand scale. And if the calculus is super tenacious, for me, an ultrasonic is not going to cut it. I have to use a piezo. So after I do my initial, overlapping strokes with the ultrasonic around every tooth, every surface, I do still go to the distal linguals the way that I also do my scaling. So I will insert my ultrasonic tip on this distal lingual pocket, and I'm actually quite amazed at how much black subgingival calculus comes out, even though I already did one pass from the buccal and from behind the patient on the distal. When you hit it at this angle, like with scaling, it's a quite significant amount of black calculus comes out. So definitely take post-op x-rays. It's huge. Everything that you just did on this patient is absolutely for nothing if you don't double check your work with a post-op x-ray, and if there's calculus, to lay the patient back down and to get it out. I hope you guys liked the video. Give it a try. I know the very first time when you're doing a new technique, it may not work as smoothly as it did for me in the video, but I promise, just give it a chance. It does work. The proof is in the post-op x-ray. Good luck.